السلام عليكم. شكرا جزيلا أستاذ دكتور حسن عشان الدعوة. And great thank for Egyptian group of endoscopic ultrasonography. أنا فرحان جدا أشارك بالمؤتمركم وأتمنى أن أكون موجود يومكم، بس للأسف الوقت اللي تعرف الفيزا. Thank you very much for your kind invitation. I will try to be restricted to the time, and I have I don't know why not moving the slide. I will present to you a very interesting case, my case presentation. You can see my slide, I think.
Yes, everything is clear.
Okay. My patient is a 49-year-old male presented to us with upper abdominal pain and weight loss of about 5 kilograms of the last few weeks. He's non-diabetic, non-smoker, and non-drinking ethanol. There was no past medical history of any chronic medical disease, no family history. All are unremarkable. On physical examination, there was no pallor, no jaundice, and no itching, no scratch mark. Abdominal examination was unremarkable, apart from some tenderness over right upper quadrant abdomen. So the patient did intra-abdominal ultrasound and CT scan, which revealed there was two pancreatic mass, one in the pancreatic head, well encapsulated around 60 by 50 millimeter, and pancreatic tail mass 55 by 45 millimeter, with central calcification, multiple peripancreatic and mesenteric lymph node seen less than 10 millimeter. Carbohydrate antigen 19-9 was 63, slightly elevated. LDH was normal. So we did baseline investigation, including serum albumin, serum alkaline phosphatase, liver enzyme, or normal amylase, lipase, hemoglobin A1C, blood sugar, urea, creatinine, all were normal. You can see baseline investigation completely normal in this patient. So the patient sent to us to do endoscopic ultrasound. There was suspicion for pancreatic neuroendocrine tumor. During endoscopic ultrasound, there was a bulky pancreatic body and normal, slightly dilated MPD, but in the body was normal. And there was a two big mass in the pancreatic head and the pancreatic tail. So we decided to do USFNB using 22 gauge Trident microtech needle, two passed them by different FNB needle. You can see in the video, this is from the duodenal bulb. As you can see, there is a fluid in the duodenum, and we use a Pentax curvilinear array and Hitachi ultrasound the mass in the pancreatic head. The scope was not fixed in this case. It was very strange, provided there was implanted masses in the head and in the tail. So the scope was frequently, we went to the second part and in the bulb. This is a antrum. You can see the portal confluence, normal. The pancreatic duct were normal, and the CBD were not dilated. This is splenic vein. This is a pancreatic body to tail junction, and this is spleen. But when we draw the scope to the tail, we see a big mass, hypoechoic mass, not vascular mass. Actually, we couldn't do a contrast study because not available in my country. And so we use only color Doppler. This was non-vascular. This is splenic hilum. It was normal. So we decided to perform FNB from both of the mass. There was some calcification you can see in the pancreatic tail mass. We used 22 gauge needle to puncture the mass from the gastric view, and we used 22 gauge needle, and after excluding any intervening vessel between the mass and the FNB needle. You can see we did two passes from the tail, rapid to improve method using fanning technique, no stylet, no suction. Usually this is our policy. And we do a macroscopical examination of the tissue after rapid on-site macroscopical evaluation after the aspiration, after the fine needle aspiration biopsy for adequacy of the tissue. We were sure that there is a very good core tissue of about 1 to 2 centimeters. So we decided to stop from after two passes. And then when we are sure that there is there is two mass because of further evaluation and characterization of both of the mass. So we decided to perform also from transducinum from the big mass in the head of the pancreas. In this video, you can see the mass is provided implanted or well localized mass in the pancreas with normal surrounding pancreatic texture. There was some compression on the SMV and adjacent vessel, but there was no any abutting or encasement of the surrounding vessel, including SMV, SMA portal, common hepatic or celiac axis. So you can see the mass in the head very big, around 5 by 6 centimeter, hypovascular mass by ordinary color Doppler. So again, we use another Trident 22 gauge needle, separate needle in the head transducinally. So we took FNB from the from the mass of the head also. We used, as I said, a different needle. So you can see here, there's a needle, and we are going to the mass rapidly without with no puncture in any vessel, and so different passes, including using technique and sometimes coming out from the capsule of the mass, more than 20 passes them through one puncture. So after evaluation from the first pass, there was very good core tissue. As I say, we don't perform any suction. Sometimes if we feel that the mass is very hard, specifically in patient with chronic pancreatitis, we use slight aspiration by 10 cc syringe or 5 cc syringe. Otherwise, we don't use negative pressure syringe. So our suspicion was pancreatic neuroendocrine tumor. So after performing the FNB, you can see in different direction. So sometimes we came out from the mass, and we are sure that there is good adequacy of the sample which we were taken. So the histopathology change came very surprisingly to be pancreatic amyloidosis, and there was congruent staining positive, which I will show you in the next slide. And there was no light chain restriction. This means excluding kappa lambda chain, excluding light chain amyloidosis, usually in multiple myeloma or monoclonal gammopathy. And there was positive amyloid trans-tyrosine on immunohistochemical staining, which is usually include systemic amyloidosis or familial amyloidosis. This is a slide from our pathologist. As you can see, mentions very good adequacy of the sample to 1.5 centimeter of both of them. The congruent was positive. No light chain restriction is being excluding multiple myeloma or other monoclonal gammopathy. Positive amyloid trans-tyrosine stain on immunohistochemical study, which is consistent with amyloid, trans-tyrosine amyloid. As you can see that there is marked deposition of the amyloid haloid material replacing almost of the pancreatic tissue. There was no any neoplastic lesion seen, and we perform immunohistochemical staining, excluding SA amyloidosis, excluding light chain amyloidosis. And then we send the sample for formalin fixed paraffin embedded tissue slide for kappa lambda chain also were negative. So the conclusion based on the result of immunohistochemical immunofluorescence study confirmed the diagnosis of rare type of amyloidosis called trans-tyrosine related disease. This is hematoxin eosin seen. You can see diffuse deposition of the amyloid tissue with a few plasma cell and pancreatic cell in between. And the congruent stain characteristically is strongly positive. You can see orange color after applying congruent staining on the slide. And this is another slide. So SA amyloid also were negative, some amyloid were negative. And this is amyloid trans-tyrosine staining on immunohistochemical stain. You can see strongly positive. Provided that it was a very strange diagnosis for us. So we sent the patient for bone marrow examination, including aspiration and biopsy were normal, serum troponin and cardiac pro BNP were normal, echocardiography was normal, and serum urine protein electrophoresis were normal. and the patient no history of the same condition. So this patient diagnosed with a very rare type of amyloidosis, which is related to ATTR amyloidosis, which is a systemic type of amyloidosis when there is deposition of amyloid. Specific type misfolded transthyretin. There are two main types of this form, usually wild type and hereditary, which need to do genetic study, which is not available in our country. So we are waiting for the result of the gene study to differentiate this type of the amyloidosis. This patient really very rare. We searched in many literature. There is no any case report of ATTR related pancreatic amyloidosis to our knowledge. There are few medication can be used for treatment of this situation, but usually most of them are not effective. They say that you can do liver transplantation, kidney transplantation, or if there are liver or kidney involvement, but in this patient there is no any sign of involvement, and sometimes the patient need to do left ventricular assisted device if there is heart involvement. And thank you very much.